What is urine osmolality? Urine osmolality is determined by the concentration of solutes in the urine. Sodium with its anion, mainly chloride, potassium with its anion, urea, glucose if present, and ammonium. Urine osmolality is measured using an osmometer. Calculated urine osmolality accounts for the concentration of osmotically active particles in urine, primarily including sodium with its anion, mainly chloride, potassium with its anion, urea, and glucose. So the difference between measured and calculated urine osmolality is the urine osmolar gap and represents the concentration of ammonium salts. As you see, calculated urine osmolality equals 2 times the sum of urine sodium and potassium plus urine urea nitrogen divided by 2.8 plus urine glucose divided by 18. The multiplication by 2 for both sodium and potassium accounts for the fact that these cations are balanced by anions, primarily chloride, in the urine. This ensures that the calculated osmolality reflects the total osmotic contribution of these electrolytes, including their anionic counterparts. The divisors 2.8 and 18 are needed to convert the urea, nitrogen, and glucose concentration units from milligrams per deciliter to millimoles per liter. A normal urine osmolar gap is approximately 10 to 100 milliosmoles per kilogram, with urinary ammonium excretion being approximately one half of this value, that is, 5 to 50 millimoles per liter, due to accompanying univalent anions, whether chloride or any uncalculated anions such as keto acids. Now, that was an introduction to the use of urine osmolar gap in cases of normal anion gap metabolic acidosis. In a previous video, we discussed that the urine anion gap plays a significant role in the diagnosis of normal anion gap metabolic acidosis. In some cases, the negative urine anion gap is between -20 and 0. In other cases, the positive urine anion gap is between 0 and 20. When the urine anion gap values are between -20 and 20, it is inconclusive or unreliable. So, the urine anion gap can become unreliable under certain conditions, such as polyuria, which can dilute the concentrations of urine electrolytes, including sodium, potassium, and chloride, or high urine pH. When the urine pH exceeds 6.5, the dissociation of ammonium to ammonia and hydrogen ions is favored, reducing the amount of ammonium ions available to pair with chloride. Or when urine ammonium is excreted with anions other than chloride, such as keto acids, as in diabetic ketoacidosis. Back again. In cases where the urine anion gap is inconclusive for values between -20 and 20, the urine osmolar gap can be used as an alternative way to assess unmeasured urine ammonium. In the absence of acidosis, a urine osmolar gap of 10 to 100 milliosmoles per kilogram is typical. But in the setting of metabolic acidosis, the kidneys should increase ammonium ions excretion to buffer acid. Since ammonium ion is not directly measured, the urine osmolar gap serves as a surrogate marker. A urine osmolar gap of less than 150 milliosmoles per kilogram suggests low ammonium ion excretion, which is inappropriate renal response to acidosis, seen in distal type 1 RTA and type 4 RTA. Urine osmolar gap greater than 400 milliosmoles per kilogram suggests normal or high ammonium excretion, which is appropriate renal response to acidosis, and that is seen in diarrhea.